Vital, our 12-month practitioner training program, is back for its third cohort starting January 2024. The last two cohorts have been nothing short of transformational, both personally and professionally, for everyone involved, and here's a little taste of what makes it so special. Vital is a process-oriented curriculum, focusing on multidisciplinary perspectives and wisdom traditions, guiding students through powerful inner work and building practical skills to support lifelong growth. Through lectures, study groups, elective modules, retreats, and process papers, you'll have all the support you need to develop your own vision and model for entering this exciting field. Applications for Vital are open until December the 20th, with early bird discounts available until November the 19th. We invite you to apply early to improve your chances of being accepted into this global community of the next generation of psychedelic wellness practitioners. So, head to vitalpsychedelictraining.com to download our full course curriculum and learn more about this transformative journey.
Hey, it's Joe here, letting you know about 2 new classes coming up that Kyle and I are producing in person. So if you're in Miami or near Denver or willing to travel, check these out. So we've been teaching navigating psychedelics for a long time, and we decided to come up with a 2-day format where you still get all of the online training for navigating psychedelics, but you get 2 different 8-hour class days with us in person. So if you want to check out the Miami dates, it's October 7 and 8, and in Denver, November 10 and 11. For Denver, again, November 10 and 11. And that's going to be really fun. So check out our website, psychedelicstoday.com/events, if you want to learn more about those classes, and hope to see you in class.
Shalom, everyone. It's David Drapkin here, letting you know that the team at Psychedelic Today have launched a brand new course. It's called Navigating Psychedelics, Jewish Informed Perspectives on Psychedelics. The course merges together the best of our Navigating Psychedelics masterclass interviews with a brand new curriculum and new teaching team focusing on the cultural, phenomenological, mystical, and spiritual aspects of Jewish psychedelic use. Over the course of 9 weeks, our group of students will meet live every Tuesday alongside myself and the guest instructor of the week. Instructors include Dr. Ido Cohen, Madison Margolin, Rabbi Zach Kamenetz, and Natalie Ginsberg. Students will also join a private online community to continue the learning and networking after completing the course. You don't need to be Jewish to enroll in this course, by the way, folks. It's open to both clinicians and wellness practitioners seeking advanced cultural competence, as well as non-practitioners that are interested in the intersectionality of psychedelic consciousness with Jewish spirituality and contemporary cultural and psychological experiential Jewish realities. To find out more and to enroll, please visit psychedeliceducationcenter.com.
Hey everybody, welcome back to Psychedelics Today. This is Joe Moore coming at you from Breckenridge, Colorado. Today on the show we have Deborah Mash. Deborah is an American professor of neurology and molecular and cellular pharmacology at the Leonard M. Miller School of Medicine and director of the Brain Endowment Bank at the University of Miami. She is also the CEO and founder of DemeRx. We got to record at the MAPS Denver conference and had a really interesting conversation, primarily around, I think, iboga, Ibogaine, and drug policy and science around this topic. I had a really great conversation with her and learned a lot. So I think you'll enjoy this one. There's a lot to say about the Ibogaine space and companies trying to bring it to market and the traditions and much more. We've not done a really great job at capturing the whole space, but we recently had Stefan Lasmi on the show, NBA player from Gabon who used this in his youth and had some interesting things to say about the traditions there. And I think we want to do more. It's obviously one of the most fascinating drugs on account of the opioid crisis. So this episode is still timely. And Deborah, thank you so much for joining, and I really appreciate your time and do hope we can catch up again soon. All right, everybody, I think that's it for the front end. Please enjoy this one. Share it with a friend if you love it, and leave us a review on places like Google, Spotify, and Apple Podcasts. All right, that's it for now. Thanks, everybody.
Are you a fan of psychedelic cinema? Well, if you've seen the film Fantastic Fungi or the series Moving Art, we've got something for you that you will not want to miss. Gratitude Revealed is the latest documentary from director Louis Schwartzberg. And thanks to Louis and his team, the film is now available for free for our entire Psychedelics Today community to enjoy. And even better, we're hosting an intimate, interactive Q&A with Louis Schwartzberg live on our Navigators platform on October 25th. So if you want to watch the film and take part in the discussion, head to the events section of our website, psychedelicstoday.com/events, and enter your email to grab the streaming link and all the info.
Hi, everybody. Welcome back to Psychedelics Today. Today, we are joined by Dr. Deborah Mash. How are you today?
I'm doing well. Thank you.
Wonderful. This has been quite the experience at Psychedelic Science 2023. Have you had an interesting time, a good time?
I was very delighted to participate as a lecturer, a speaker here at the event. And the opening session with Rick Doblin was, I can't even hardly put it into words. Walking into that room, feeling the energy and hearing Rick Doblin deliver what was undoubtedly one of the most historical and transformative narratives about where we are today and his journey to get us here. It was brilliant.
Yeah, I'm a big fan. I was not able to see it, but I cannot wait till they put it out on video. It's going to be awesome. Any other major highlights for you?
There were so many.
Yeah.
I mean, obviously, I'm here, holding the flag for Ibogaine research. And we had a lot of interest around Ibogaine at this meeting, which is just, somewhat of a dream come true for me, given my 30 plus years working on advancing this drug as a medication for the treatment of addiction. But the attendance at my lecture was surprise, and we were joined by other colleagues who were working on advancing psychedelics like psilocybin for other disorders, including cocaine addiction, alcoholism. So the groups from Hopkins and elsewhere were well represented, and that was exciting. And I heard a brilliant lecture by John Crystal on ketamine and the science of ketamine and how it is really advancing next gen, not only understanding the neuroplasticity window, which they have mapped out. And of course, they made the seminal discovery of ketamine to begin with, that it was a rapid-acting antidepressant. But to have it now where we really can see the fundamental neuroscience, you can actually see where in the brain it's bringing about the changes in dendritic arborization, so how the neurons in our brain communicate one-on-one with each other, to see this, and then to have the human narrative. They had a video, he presented the video of a young woman who had struggled from her early teens and now as a young adult with severe unremitting depression, and to have her describe how you are able to have this single dose of ketamine and then 24 hours later to just be restored to a sense of wellness. I loved it. And Dr. Crystal, the chairman of psychiatry at Yale, I mean, what a brilliant, brilliant presentation. But there were so many good presentations. Then we had the Ibogaine movie, Lucy Walker. I went to the premiere of that in New York City last Friday, but again, I sat in. And to be part of that and to see myself at all different ages and, in front of the FDA and carrying water for this was pretty impressive.
Yeah, you've been at this Ibogaine project for a bit. Let's talk about what you're up to now, and then I want to rewind the tape. We'll do now a little briefly because we'll circle back our way to it. So currently, can you tell us a little bit about your business that you're involved in?
I'm the CEO and founder of DemeRx, and it is a clinical stage drug development company advancing 2 molecules for the treatment of addiction. What we're trying to do is to target right now for opioid use disorder. And so we have Ibogaine, which is a psychedelic medicine, And then we have the non-psychedelic metabolite of Ibogaine, which is also pharmacologically active. And we believe that both of them have a place in as pharmaceuticals.
18-MC?
No, 18-MC is a molecule that was developed by Stan Glick and working with a chemist. And that was licensed to a company called Savant. This is Noribogaine, which is des-methyl ibogaine. So the ibogaine is metabolized via the liver to a pharmacologically active metabolite. This is not uncommon. Many drugs have active metabolites, but this one has a distinct pharmacology.
That's great. And seems effective, not psychoactive.
Correct.
That's a big deal.
Yes, it is. And there are others who are working in the space. You know, there's a movement for people to use psychedelic medicines as lead molecules and then to synthesize around them. Similarly, like LSD. LSD came off, an ergot synthetic pathway, right? And then from that came 4 blockbuster drugs, if not more. Hoffman's seminal research.
Yeah, LSD alone is quite a blockbuster, but yeah, Hoffman made quite a few more things.
He did. And this really was what built that company. This is what built Sandoz.
Really? The untold story.
Well, I mean, pharmaceuticals were just, think about when he was working.
It's really young pharma days.
It was very early pharma days. And before that, what we had natural products. And Mother Nature gives us natural products like Ibogaine.
Yeah. So, and you also work with a couple of universities?
I do. I was on the faculty for 3 decades at the University of Miami Miller School of Medicine in the Department of Neurology, and I had a secondary appointment in pharmacology. So I'm a neuroscientist, neuropharmacologist, but I worked in a clinical department and have been a NIDA-funded investigator since 1992 to the present. So I've, done a lot there. I'm the former founder and director of the University of Miami Brain Endowment Bank, one of the largest postmortem collection of brains donated for medical research. And these very precious tissues are what have been used in the studies, not only of the neurochemistry of the brain. It's what got me into studying the chemistry of the brain in the beginning and looking for chemical signals in the brain that could be targeted with drugs. So it was a drug development pipeline for me and my own research. But then later on, to be able to be part of the genomic revolution, to really be able to look at, we can now study all of the neurons in the brain for the first time and genetically phenotype them. So now we know there are subclasses of GABA neurons, and there's subclasses of glutamate neurons. I mean, this is profound. And so here we are. We're at, again, another next wave of learning about the human brain. There's more neurons and neural connections in the human brain than there are stars in the Milky Way galaxy. So it's a complicated story.
Yeah, it's the, as far as I understand, the most complicated thing we know about as of right now. And thankfully, we're able to study it a bit.
A bit. Yeah. The tools, the windows to the brain. And psychedelics are windows on, we've known this forever. And that has been written by others in the past, like Stan Grof and others who have spoken about it, is windows to consciousness.
Well, as a neuroscientist, at a certain point, you must have been a little frustrated with the tools at hand. And then psychedelics came around. Did it seem like an interesting tool for you in terms of...
Not a bit. Not a bit. No. I was, I was working on addiction. And I had federal funding. My career was going great. And we had I was a cocainologist. I was working on the cocaine epidemic because I'm in Miami.
It's a Miami thing, yeah.
Miami thing. I was, had left Harvard. My laboratory was set up. We were going strong. And I got sort of seduced into looking at addiction because there were deaths. And medical examiner couldn't really explain things because people were dying with recreational blood levels of cocaine. CDC came down to Miami. We had all this cocaine pouring in because of our close proximity to the Bahamian corridor and the transshipment of cocaine. Miami Vice, we were the epicenter of this. And a little bit of synchronicity to fast forward, person that I knew from my younger days and undergraduate days was now an MD, Ph.D., Dr. Ruttenberg from the Centers for Disease Control. He comes into Miami. He's meeting with the medical examiners. Next thing we know, they say, oh, there's this woman, Deborah Mash, in neurology. She's got a brain bank. Maybe she can work with us and we can take a look at the brains, because the medical examiner, doesn't do that kind of chemical profiling of the brain that I was doing in my lab.
That's more chemical than anatomical, right?
Correct.
Like slicing and dicing.
You got it.
Okay.
That's exactly right. Not the standard histopathology, right? So I did kind of a chemical neuropathology, and that's what they wanted. And in the course of all of that, I get seduced into, I'm going to write a grant, because if you want to study something, you have to write a grant. So I did. Got funded on a first submission. Never happens. Thank you. Thank you for that. Got funded on a first submission. It was a good grant. But there we were, and we had the money. And my colleague, I get the money, I get everybody in a room, and I said, all right, we've got our taxpayer dollars here. Let's do something. And one of my collaborators, Dr. Hearn, who was chief of toxicology, says, hey, Deborah, we should look at cocaethylene. I said, coca what? Well, the ethyl homologue of cocaine that's formed when you drink and use cocaine in combination. Miami, a lot of people were drinking and using cocaine. You'd go in the bathrooms and clubs and places, and people were hitting coke and drinking, chasing it with champagne. Cocaine, champagne, right? So I said, draw the chemistry. And with that, we ended up getting national recognition very early in the course of our grant funding.
I've talked about this study a lot, by the way. I had no idea it was you. That's amazing.
Really?
Yeah.
Oh, yeah. No,
cool.
That was my lab. Yes. Yeah. That was my lab. And with a team of great people, because I had an excellent analytical tox group around me. But we characterized it real quick. And in the course of that and getting all that publicity, the president of the university, Tad Foote, asked me to go in front of the Coalition for a Drug-Free America. You may remember them. And I said, yes, the president asked you, you go. And I get up there and I give my little lecture on cocaethylene, and a black gentleman came up to me afterwards and said, have you heard, Dr. Mash, of this drug from Africa that can be used to wean people off of hard drugs like heroin and cocaine?
Wow.
And it was the first time I heard the word Ibogaine. And I looked at him and I shook my head and I said, no. And he was very animated and he was trying to get me to pay attention. And I was like, I don't know what you're talking about. I've never heard about this. Please, sir, I'm sorry. I don't mean to be rude, but these other people want to ask me questions. And so if you don't, thank you for telling me, but I'm going to go talk to these other people. Happened 2 more times. And the third time was Howard Lutzoff made the seminal discovery that they had my attention.
Incredible. Did Lutzoff, was it a similar scenario with Lutzoff?
No, Lutzoff called me because of the cocaethylene work. He wanted to use our research to support his polydrug dependency patent for Ibogaine, which was his 5th patent.
Wow.
They've all expired, those patents, but those were the original patents.
That's fascinating. Wow. Yeah, like the IP landscape around this stuff is something I'm super ignorant of, but it's definitely got to be a fascinating story.
Well, there's not a lot of IP around psychedelics because they're old molecules, right? So you have prior art. When you have prior art that's in the public domain, you cannot patent. You get struck on novelty.
Yeah. So from what I understand, there was a lot of French influence in Gabon, right? And there was like really early pre-pharmaceuticals that involved Iboga.
That is correct.
That were available in France for a long time. So like the French had exposure.
Yes.
Well,
what they had was Lamborine. Lamborine. It was marketed under the trade name Lamborine. 32, they were tablets. People were taking about the equivalent of 32 milligrams a day. And we know from the work that I've done, looking at dose and metabolism of Ibogaine, that when you take a low dose of Ibogaine, it has what is called a high first pass effect through the liver, and it gets converted to the metabolite, Noribogaine. So these people were dosing Noribogaine.
Fascinating. So Why were they using it? Was it energy or?
It was antidepressant,
Okay.
mild stimulant.
Mm-hmm. Cool. And is it 18 milligrams? Was it
30.
30? And I
30
assume
of
that's
Ibogaine.
like Ibogaine specifically. Okay, cool. Not the whole plant. Yeah, people are using like large spoonfuls. I have no idea the percentage by
Terrible.
weight. It's really
Terrible.
low by weight.
Well, we don't know anything about that. When people take raw, root extracts, you have no idea what you're taking. None. Because the roots are going to vary. Root to root will vary. So if you get a good root, you're going to get a lot of Ibogaine. If you get another one, you'll get less. That to me is very frightening. I worry about people who buy, especially people who are treating addiction disorders, who buy Ibogaine, the impure extracts of Ibogaine on the internet, which people get. And because you don't know how to dose it. And Ibogaine, unlike the other psychedelics, which can be very safe over a very wide range, we know that Ibogaine has a narrow therapeutic to toxic range.
Can you tell us a little bit about QT elongation and what that whole story is about?
QT-prolongation. All right. The heart has a refractory period. And in order to have a sequence of normal beats to beat, you have to have repolarization of the heart. So, you go through, you know what the EKG signal looks like, right? It has a waveform. And then you go again, and then you go again, and then you go again. If you have a lag in the repolarization or an issue with repolarization, then you can get into trouble. And that can lead to what is called a proarrhythmic event. And various things can add risk, can put you at risk for this. Okay. Some people are born with inherent risk. They have what is called long QT interval. We all have a QT interval. Mine's quite good, actually, I have to say. I've had it measured recently, and for my age and whatnot, I could take all kinds of Ibogaine because my heart is very safe and it's in healthy condition. I have a low QT interval. But there are people who are genetically at risk that harbor genes or risk alleles that can put them have an adverse event on a lot of medication. Methadone is also a QT prolonger. Other CNS drugs are QT prolongers.
This is why we need people off of methadone before they probably take these other things. Maybe they need a different opioid, right?
The rule here is not completely understood because the group in Spain, they're is doing a methadone taper, which is basically a methadone interaction study with Ibogaine. And they're giving dose of Ibogaine every week and trying to taper people off of methadone. And they're not reporting a profound effect on the QT interval, but we know exactly as you have said, methadone is a QT prolonger. And if you have two QT prolonging drugs, you're going to get an additive effect. But they're not reporting any adverse events here.
So there's a number of from what I recall, somewhat high profile deaths related to Iboga, and sometimes people just die when they're consuming it. And I was chatting with somebody recently from Gabon, and they were reporting to me that the tradition suggests that it's not just QT elongation that causes that. They're like, oh, they're on all these other drugs. Their diet's not clean, blah, blah, blah.
We published on this.
Okay.
So absolutely. I mean, in the public literature, in the peer-reviewed literature, the reported literature, there are 33 deaths that are associated with Ibogaine. You can't always do what is called a causality analysis because there are so many other factors. One, they didn't measure the concentration of Ibogaine in the blood or the metabolite in the blood. Start there. The impurity of the drug product. They didn't test the drug product. We don't even know what the drug product is. They may have not done toxicology to see if it was a drug-drug interaction. The person may have been on other drugs, and in some cases, indeed, they were. So that contributes. Then you have people who have underlying cardiac risk. They don't have a healthy heart. And for people who are abusing drugs and alcohol, They often don't have a healthy heart or a healthy liver. And ibogaine is metabolized, as I explained, through the liver. Then some people stack doses. I have really spoken about this, how this is a bad idea with ibogaine. And that has caused issues because they've gotten into a toxic range. So they just simply took an overdose of ibogaine. And last and most likely, one of the predisposing factors, well known in the medical literature, well known in the cardiology literature, is electrolyte imbalances, potassium and magnesium. And if your electrolytes are off, you're going to be at risk.
I guess a lot of people with like really hard living, of course, their electrolytes are not in a good situation.
Right. You've been banging back freebasing a lot of Coke, your volume depleted, and your electrolytes are off. Opioid abusers, magnesium, potassium disturbances. So these are manageable things, but you have to have ibogaine administered by knowledgeable doctors who understand that it's an investigational drug, who have a pure product of ibogaine. They're not just buying some, internet product that you know nothing about and then try to assume a dose from that. You cannot. You have to have a proper dose of the drug. You have to understand the impurity profile of your drug product. And this is a problem. This is a problem. And I believe that this is the primary problem. But that's why we in our company have had to go back, because every time there's some report of some adverse event or a torsade episode or someone, because that's a life-threatening arrhythmia, then we're the ones who have to bear the brunt of that. So these underground practitioners or people who maybe they mean well and think they can handle the drug product, but they can't.
Well, let's dig into that. So what are we at? Like about 100,000 opioid overdose deaths a year in America right now?
Yeah,
roughly speaking.
It's about a plane crash a day.
So, and there's roughly 30-something deaths from assorted ibogaine related situations. So
and there may be more that are not reported.
100%. We have 100%. Yeah, no doubt on that. Seems like an okay risk profile. Just off the cuff, if I'm looking at it.
It benefits to risk. And this is something the FDA is exceptionally good at.
Not that I don't want amazing products available. I always want amazing products available.
Amazing products. We want amazing products. But
even if it's like plant, whatever, as long as we kind of know the potency. If we're doing it over here, I want those people to keep doing what they're doing over there, like in Gabon. Like the tradition should keep going.
I have no comment on the use, the sacramental use and the ethnobotanical use in Africa. And indeed, we can learn something from them as well.
Probably a lot, yeah.
However, we're talking about medication development for the treatment of addiction. We're talking about administering ibogaine in a hospital setting. We're talking about giving people who are at the last road. This is for some people.
They very much might not make it.
This could be life and death. Their current drug use. They're going to be checking out. So I always felt very strongly that you needed to give people the safety so that when they took ibogaine with us, we had the first clinic, government-approved clinic, drug in the pharmacy in the country of St. Kitts, West Indies, and this was started in 1996. People flew in a lot of bad condition, and our medical team treated 277 people. No deaths.
Wow. That's excellent news. Yeah. Yeah. That tracks with the ratio earlier too. So that's excellent. So is that still in operation?
No. I was working full-time at the University of Miami, and this was the only way I could get the data, because even though we had FDA permission to test the drug in the United States, the FDA was wonderful and really was collaborative with us when I brought.
I don't hear that often.
No, you don't, but I can tell you that with this they were, okay? And I had wonderful medical safety officers who helped to guide us when we brought this to them. And they were all for it. They wanted us to get into the clinic and start the phase 1 testing, but I couldn't fund it. And Howard Lutzoff controlled the patents. There was no way for me to raise money. I'm an academic, but the door closed. So I ran 2 dose range of the arm, 2 of the doses in the arm that the FDA wanted us to do. And then we had no funds. Actually, MAPS gave us $50,000. Rick Doblin gave me my first grant to help support our research. Because he has always been a proponent of Ibogaine. But it was rough and it was very disappointing because here we were. We had an excellent medical team. We had experts in pharmacokinetic modeling from University of California, San Francisco. I write a grant. I'm a grant writer. I write a grant. I spoke to the National Institute on Drug Abuse and I asked them to fund us. I said, help us. I brought them in with me when I went to the FDA. I invited them to listen and be there. And they weren't ready. It wasn't prime time for psychedelics, right? Didn't get the money. So my choices were 2, shut down or figure something else out. And that something else out was to go offshore, to go ex-US. And that's what we did.
That's excellent. Did St. Kitts just not have it scheduled in the same way we had it here?
No, it was under the DEA license. Yeah, it was under the U.S. regulatory laws through especially with the cocaine coming through and everything. No, those countries, it was difficult to bring drugs, Schedule I, into that country. But the prime minister himself was a medical doctor. And when I met with the government officials, and I had a wonderful clinical director, Dr. Frank Irvin, who has since passed away. But Dr. Irvin from McGill University, a biological psychiatrist, skeptic, he was our clinical director, and he had worked with the government. So we had all the bells and whistles, we had all of it. And it was, I think, when I think back, it was some of the best work of my life because we had people so sick. And today, even now, I still get emails and text messages. Dr. Mash, I'm still clean. This is my, 20th anniversary and things like that. And, it never loses importance for me because, we made a difference.
So many people.
Oh my God. Yeah. And I get flowers on Mother's Day. And there are so many people that call me, write to me, families write to me. When can we get this? Can you help me? What can I do for my son? We don't have the money to go to Mexico. And because of, Caribbean or where there's a clinic in the Bahamas, there are all these clinics, but you have to pay for treatment. And some people can't leave the country because they don't have a passport. And look at the underserved in our country. And this is and here's an African sacrament that could alleviate potentially, if we can demonstrate to the FDA, the benefits outweigh the risks, could treat a lot of people.
We have to be getting close. So I'm sure you're familiar with what happened in Colorado recently. There was all sorts of interesting deliberation after the governor executed the Prop 122 into law, right? I think this state Senate majority leader out of Boulder came back with this radical revision. And I was like, okay, the whole thing's gone now. This isn't anything we voted on here in Colorado. And through activism by the psychedelic community here in Colorado, they were actually not only able to revert a lot of those really kind of not great changes, but they were able to say, okay, yeah, at the same time we're implementing psilocybin, let's actually begin right now also trying to work out Ibogaine. It was always part of the plan. It was just going to come years later. But they said, there's too many people dying now. There's too many people suffering now. Let's figure out how to implement this and have a state regulatory body that can help with manufacturing testing and stuff. I really would be interested if there's a pathway for your organization to be providing for some of the clinics here in Colorado.
This is a big question.
Right, federal and state.
It's federal and state.
It's going to look like cannabis or something.
Yeah, no, it's federal and state. And I think the momentum, and this is not the first time, because I gave testimony in the state of Maryland, in the state house, how many years ago, probably 4 or 5 years ago, where they were trying to do an initiative around Ibogaine, and it did not get legs. Ibogaine is not like psilocybin, all right, or ketamine, which is already approved in clinics. MDMA will be made available once they get past the FDA, and these clinics will open up, and that will be used. To bring Ibogaine in is going to require several things. First, it's going to require an IND being opened in the United States. The old IND that I had is closed. So we have to open a new IND. The FDA is going to have to re-review all of the scientific information about Ibogaine in order to make a judgment about allowing this to be tested. Normally, you would do a phase 1, which was what I started with, phase 1, and then the phase 2 and the phase 3. I believe, as I sit here today, that there are enough data to support a safe dose range, that we know enough information.
Totally.
But but it's not totally, because the real world evidence, there's no blood levels. And Ibogaine is complex pharmacokinetics. You have fast, slow, and intermediate metabolizers, and you also have ultra rapid metabolizers. We don't have a lot of data about females. I genotyped people. I did this in St. Kitts. We have that data. We know something about this. I've mapped this out and I've published on it. We have some ideas about exposure. We understand metabolic ratios between the parent and the metabolite. FDA is going to want to see all this. They need to see it, because otherwise you can't be certain about dosing people. You don't want to go into patients and not have that information locked up. All right. And a lot of people, we don't even know what drug they took, unfortunately. And I've been begging the clinics to gather more data, more, medically relevant data.
Right. Like partnering with clinics seems very sensible.
It does, doesn't it?
Like, is there any kind of coalition around coalition in the retreat space, or just Ibogaine space generally?
I'm moving in that direction, to be honest. I won't name names right now, but I am moving in that direction, because you're right. We can't sit around and wait. People are dying, Yeah. The patients are calling us. People need this. And if it holds the promise that we believe it does, and I have to always maintain a bit of healthy skepticism, because I'm the one who's going to take the arrows and take the fire.
We got to have a scientist in the room.
You have to always be a little bit internally skeptical about your own data, and you have to, because you want to look at that data so that you can see an angle. If there's something you miss, if you're not looking at it critically, you're going to miss something. We don't want that. But I think you're right. So I am looking to collect some of the type of data that we would get from an FDA-approved study in the US from the clinics, because I think that will give, I use those types of data. I use the St. Kitts data to support the filing in the UK, where we got permission from MHRA, which is the FDA equivalent regulatory body there. And all of that data was accepted and looked at, and it's important data. It's seminal data.
Yeah. Well, that's interesting. So we can get there. Yeah. What I've seen some groups do is, my favorite model right now is IPCI. It's this Indigenous Peyote Conservation Initiative. And so it's 50 different tribal interest groups in the peyote Native American church space. And they've come together to work on the conservation of peyote, it grows really slow. It's really popular. It's a big part of our culture.
No, and it's getting depleted.
Right.
I learned that. That's horrible.
It's not great. And the biggest person I have a beef with is John Mayer. I saw him wearing big peyote t-shirts. I'm like, come on, dude. That's not healthy or helpful for the conservation situation. So what they did is, because I think a lot of indigenous communities are very family heavy and calling in favors from cousins and uncles and whatever. They actually had to hire somebody to be the executive director who is not indigenous themselves to help coordinate all these groups so nobody would call in favors and things like that. And I found that really clever to have some sort of like
Well, it's smart.
kind of
Have an independent body.
an independent
Absolutely.
leader helping coordinate all these
Of course.
resources.
Sure.
And you're not going to keep all these 50 groups happy, right? You
No,
can't.
You can't.
Like some groups are going to pull off and complain and whatever.
Mhm.
So, the best thing they can do is hopefully just keep progressing on conservation and, telling gringos to stop using it, which I
the
I would love
stories,
that.
the stories that I heard, about the fraternity parties out there and depleting, that's horrible. I mean,
It's not good, but it's complex, right? It's like real estate development, UV exposure, cattle ranching, all these things stacked, like plus, recreationalist, and it's like really disrupting the market. So
to get
Mhm.
get back to doing
Please.
something at
Yeah.
a state level,
Mhm.
it's got to be a public-private partnership. Otherwise, it's not going to happen. And you have to bring all the stakeholders to the table. Who are they? I'm talking about the regulatory agency, not just the FDA, but the NIH, the National Institute on Drug Abuse, the academics that are in that state. So in the state of Kentucky, you have leadership with Sharon Walsh. Dr. Walsh is world-renowned addiction expert. You need to have these people behind this initiative. I think you go slow, you go steady, you bring in the stakeholders, and you bring in the consumers, and you bring in the families, because addiction is a family disease. When you do that, you have pure product that the FDA can review the chemistry and manufacturing and control data. You demonstrate stability of your drug product. Now you have a dose. Then it becomes safety. What's the design? How are you going to administer Ibogaine and where? And who has the qualifications to administer the drug?
Mhm.
I believe that Ibogaine should be administered, and I've said this and published on this, under full medical monitor. It should be given in a hospital. And I have spoken with some very large chain.
I can barely afford to go to a hospital
No, it's no. People go
or
to
see it, even a doctor.
people go for
Yeah.
hospital detox.
Mhm.
People go to the hospital for
Good
detox.
Lord. Yeah.
Okay, they go to the hospital for detox,
Mhm.
and emergency rooms are seeing people in withdrawal. You could take people, stabilize them,
Mhm.
and then get them ready for Ibogaine. They could be
Mhm.
randomized to Ibogaine, or they could be randomized to buprenorphine maintenance.
That would be an interesting trial design. Given Colorado's going in this direction soon, I don't know how it's going to look. It's going to be fascinating to see. I think there's room for a pilot of some kind in Colorado that Colorado probably has an obligation to fund. And I would love to see something along those lines.
Right? We've been
Yeah.
thinking about this, and I've also developed, our funding is coming from Atai
Mhm.
Life Sciences, and, we have multi-kilogram quantities of Ibogaine right now. We have all the
Wow.
building blocks of
Mhm.
what is needed to get into to have a discussion,
Mhm.
a frank discussion with the FDA,
Mhm.
and that's what we need to do. We
Mhm.
need to say we have state support for this. We've got state dollars for this. We want to partner together with the FDA and with Atai, DemeRx, to start to run these pilot studies in
Mhm.
a controlled environment.
I'm
This
seeing
can
the
be
problem.
done.
So what I was missing was that because you're dealing with the FDA and bring drugs through the pipeline, you have different sets of restrictions than someone that's just say an Ibogaine manufacturer purely.
You can't administer. Ibogaine is a
Mhm.
Schedule I drug. You're
Mhm.
not going to get permission to administer or manufacture in the U.S. for U.S.
Mhm.
use if you don't file with the FDA.
Well, right. As a drug company, as like you're bringing it through the FDA
An
pipeline.
academic could do it. I wasn't
Yeah.
a drug company. I filed with the FDA as an
Mhm.
academic investigator.
Yeah.
So an academic in that state
Yeah.
could file the trial,
Right.
but they still have to file the IND.
Oh, there's
Now,
still
if
IND involved.
there's still an IND involved.
Yeah.
So if I had an IND
Mhm.
sitting there, other people could reference our IND if I gave permission, for example.
Mm-hmm.
So there could be a coordinated effort. And I think this is how it goes.
Mm-hmm.
And I think it could be done in multiple states. And what would be brilliant about this is this could bring efficacy data,
Mm-hmm.
safety and efficacy data.
Mm-hmm.
In other words, address the benefits outweigh the risk
Mm-hmm.
quickly. Once you have that database and you have that presented to the FDA, then you can get very, very creative and you can move towards what is called compassionate use or patients' right to try.
Mm-hmm. Yeah, right to try is lovely. I do love that one.
And then you can go very quickly and collect
Mm-hmm.
even phase 3 data, which where you're giving, you're expanding your safety database in phase 3. But you have to have that pivotal phase 2 data. Now, the other thing is that I've been working with a group because setting, I'm talking about doing this in a hospital, right, under full medical monitor.
Mm-hmm.
You're hooked up to cardiac monitors, you've got IV lines up, you're in a safe environment, but you have your eye shields, your headphones. And what we've are developing is a VR device to help with the psychoeducation, the preparation, the anxiety relief, the mindfulness, and then post-Ibogaine integration in a VR environment.
Interesting. You all are doing that on your own?
Yeah, DemeRx is doing
Yeah,
that.
that's fascinating.
With Firefly. And they've done something similar for ketamine. They have the ketamine sanctuary, and we're developing the Ibogaine sanctuary.
Ketamine sanctuary sounds curious. I'll look into that. That's fascinating.
Yes.
I'm a big tech head, so I love the
well, you'll
the
love what
there.
we're doing.
Yeah.
I'm very proud of it, and
Great.
I have a lead addiction therapist who is advancing this with us with the content, and I think we're state of the art. I really do.
It's great. So, what else is in your pipeline, or what's hot for you right now as we kind of close up in the last few minutes here?
Advancing these drugs.
Yeah.
And the metabolite, we're also going to be talking to the FDA about moving Noribogaine, the active metabolite, because originally I had thought that...
And we can manufacture that.
That's not scheduled.
Okay.
And I have multi-kilograms of that too, ready to go.
Oh, man. I've never had multiple kilograms of drugs on hand.
No,
but that's amazing.
It costs a lot of money to get those. There was a large investment at the Atai level to help us to get ready for this.
Mm-hmm. Amazing. Well, I'm just really thankful that somebody like yourself has been on this for so long. I'm sure it hasn't been easy. I'm familiar with a few of the battles, but not a lot of them. And I just know it's taken a lot to stick through this battle, but it's worth it to see people become healthy again. And you already experienced it.
Yeah,
right?
I have. And you get one shot on goal. I mean, you get one shot in your life to make a difference. And this is my one shot on goal. But
I love it.
It's the old Nietzsche quote. That which doesn't kill you makes you twice as strong, right? Makes you stronger. Conan the Barbarian. And if anything, Ibogaine is the hardest psychedelic to work with. But I'm here for the challenge.
You just sent me in a funny direction. I think I have to read a bunch of Nietzsche and then watch Conan again. Or read it. That's so funny. Wow.
Well, thank you. Thank you for a great interview.
Well, yeah, thank you for your time too. Thank you for all your work. And I hope we can stay in touch about it. And I would love to keep learning about what you're up to.
Indeed. See you soon.
Yeah, thank you.
And there you have it. Deborah Mash from DemeRx and the Leonard M. Miller School of Medicine and the University of Miami at the Brain Endowment Bank. Super cool. And I hope you learned something about Iboga, Ibogaine, the process of making a drug, things like that. And again, this was recorded during the MAPS conference. We were downstairs in a podcast row. It's pretty fun. And again, thank you, Deborah. Really appreciate you being on and hope we get to do it again. All right, everybody. Thanks for tuning in, and we will see you next time. This is Joe Moore signing off for Psychedelics Today. Bye-bye.